Good evening and happy Monday. I hope your weekend was great. And for those of you who are fathers, I hope you had a great Father's Day yesterday. I had a very relaxing Father's Day yesterday and I'm very rested today. We have a great show planned for you tonight. Of course, we always have a great show planned for you on Monday evenings. But today's going to be a little bit different in that it's going to be a case presentation. A friend and colleague of mine sent me an article that was pretty interesting, and it was a publication of an autopsy of a patient who had been vaccinated with COVID. However, as I reviewed the article, there were a lot of interesting clinical findings that I thought would be worth discussing. And so what I'm going to do is in our training, we had what would be referred to as morning report for internal medicine, or there was also morbidity, mortality report, there's M&M conferences where we would discuss, case histories. And so this is going to be a little bit of an M&M presentation where I'm going to go over the case history. Unfortunately, this patient died, but there was an autopsy done, and there was some details from the autopsy that was made available. So I'm going to give the case presentation and share some thoughts on this patient. And my panel will be here and they're going to weigh in with their comments and commentary. So I want you to sit back, get a pen and pencil ready. There's going to be a lot of information shared with you, and just sit back and enjoy for the next 60 minutes. We're going to get started in just a minute. Okay, so I'm going to bring on my wonderful panel and guest who's going to be joining me in the studio. We have with us as our guest panelist, Joanne Farb. Joanne, how are you doing this evening? And
Hi, I'm good.
Joanne shared this article with me, and so I called her somewhat last minute. And I'm going to turn my mic down a little bit. I called her somewhat last minute to come in the studio with us and share her comments on this. We have Dr. Floyd Atkins. Hello, Dr. Atkins. How are you doing?
Hello, how are you doing?
Good. We got mic check there. And Dr. Pamela Atkins. How are you doing, Dr. Atkins?
Good evening. I'm doing great. Good to see you again.
Good. Everybody's mic. I hear some background noise somewhere. I don't know if someone has that background noise. If you can check it out or mute your mic or whatever the case is. But anyway, so I'm not going to delay this. So I'm going to jump into my slides and guys, just sort of, and feel free to interject as usual, because I interject when y'all are presenting. So feel free to interject. But we're going to get on to this case. This is an autopsy of a COVID-vaccinated patient. And, I emphasize COVID-vaccinated patient because that was the emphasis of the article. However, I think there are a lot of clinical information here beyond just, the COVID vaccination of this patient. I'm going to share some of my thoughts. This was published, and this patient was in Germany. This clinical scenario was in Germany. It's published in February of this year. They finally accepted it in April of this year. And so they initially presented it in February of this year. In a pretty well-known journal. So what happened here? What was the clinical situation? So I want to start off with a baseline condition. Typically, when we talk about case presentation in our training, for those of you not familiar with medical training, the doctors that will review a case that's gone through a patient that unfortunately died, they may do a morbidity to mortality conference. And sometimes these things, certainly in my training, in my area, these things are pretty contentious. I mean, you would, get attacked in morning report or morbidity to mortality. So It wasn't always fun, but we're not going to attack anyone here. We don't have anyone here to attack, but we wouldn't attack them if they were here. But there's an 86-year-old man who lived in a retirement home, and he received the COVID vaccine. So I want to point that out because that's the emphasis of the article. So it's important to point that out. Now, of note, he had a medical history of arterial hypertension, chronic venous insufficiency, dementia, and prostate cancer. So I'm going to explain some of these over the course of the discussion, but I'm just going to get the information laid out. On January 9th of this year, he received the Pfizer COVID vaccine. So that was the first dose on January 9th. And so on the following day and 2 weeks after, he had no symptoms. So he got the shot, and after that, no symptoms whatsoever. However, there was a clinical change on the 18th day, such that he was admitted to the hospital for worsening diarrhea. Now, I emphasize worsening diarrhea because apparently the diarrhea had preceded day 18. And as we'll see, it was actually on day 15, he passed out at the breakfast table. It wasn't pointed out in the body of the article, but on an outline, it showed that he had passed out at the dinner table. So it implies that he may have had diarrhea probably starting on that day, if not before, and he may have been dehydrated, but I'm just kind of throwing those clinical speculations out there. So, however, he was admitted to the hospital. He tested negative for COVID in the hospital, so therefore he wasn't put in isolation or anything like that. And laboratory tests, so initial labs, and there's a chart I'm going to go through. It's pretty busy, and we're going to look at some of the details of the labs, but we do know from the outset he was anemic and he had some abnormal kidney function. Now, I want to put the abnormal kidney function in quotation marks because I do think a patient at this age and with this medical history probably has some intrinsic kidney disease. But I also think part of that kidney dysfunction was due to dehydration. Why do I think that? An elderly man who probably is dehydrated at baseline, he has probably at least 3 days of diarrhea. He's losing a lot of fluids and electrolytes, so he's probably a little bit more dehydrated than baseline. So some of that creatinine abnormality is dehydration. These are some important factors that we're going to have to remember. So remember anemia and remember dehydration as we discuss this case going throughout. So he had another COVID test done, and it was negative. And so he had multiple COVID tests throughout his hospitalization. And he was negative upon arrival. A colonoscopy was done, and this was done because of the diarrhea. Now, they saw an ulcer at the left colonic flexure. That's right about here. This little diagram shows that. And the biopsy and histology showed ischemic colitis. Now, for those of you who are taking notes, write down ischemic colitis. It's right there on the note. That's an important factor, I think, as we discuss and how this case factors and how things play out. So ischemic colitis. So further testing his hospital course. So he had the biopsy was tested for COVID. It was negative. So when they biopsied the ulcer in his colon, they tested that for COVID, and they didn't find any evidence of COVID in the colon. So then, so what did they do? They treated him with mesalazine and IV iron. The mesalazine is sort of an aspirin-like drug. It's usually used for inflammatory bowel disease, such as Crohn and ulcerative colitis. And that's an important factor, too, because remember what the biopsy showed. And now let's think about what they did to treat him, because I'm going to have some comments to say about that. So make a note of mesalazine and also the diagnosis of ischemic colitis. So subsequent condition deteriorated. He developed more renal insufficiency on day 24. He had a roommate that tested positive for COVID. Now, he was COVID negative up until, and I'm just recalling from a, a graph that showed him to be, there was a chart with a record, and up until day 20, he was COVID negative. And so on day 25, however, after being exposed to the COVID positive patient on day 24, our patient tested positive for COVID. So the first time he was tested positive for COVID was on day 25. Now, Another factor here was that there was a low cycle threshold. Now, many of us are not experts in PCR, but the PCR test is a test where they can take a small amount of DNA material and amplify it so that it's more easily detected. And so it increases the ability. It's certainly beneficial in research, but some diagnostic use is applied. I'm not sure if it's best used in the setting of screening, but the amount of amplification of that DNA material is based on the cycle threshold, the amount of cycles they run on the amplifying the DNA. And so a low cycle threshold is a low amount of amplification. A high cycle threshold is a high amount of amplification. And so the higher you have to do the cycle threshold, the higher amount of amplification takes, the less genetic material that there is. And so the lower the amount of cycle threshold, the higher the amount of genetic material. So it's important that they pointed out here that he had a COVID positive test with a low cycle threshold, indicating a high virus load. Now, remember, he had no evidence of viral infection 5 days prior to this, and probably did not have any infection until 1 day prior to this. So he had, in probably 24 hours, maybe 36 hours, went from no infection to an infection with a high viral load. So that's an important thing to remember as well. So there's no evidence of a mutant COVID. That's important because he had the vaccine for the wild type, and so there's no evidence of the mutant virus, and so that's important to know. The other findings that he presented with fever and respiratory discomfort of the lungs, auscultation. So this was within about 24 hours of being tested positive. So he became acutely ill very rapidly. And on day 26, I believe it was, he died from acute renal failure and respiratory failure that following day. So they gave him supplemental oxygen, and he was treated with antibiotic therapy with ceftriaxone. So that's the hospital course. What was the COVID-19 response? They did test for antigen to the antibodies to the spike protein. So they saw appropriate IgG response to the S1 spike protein. Okay, and so this was at 8.7 units per ml, much greater than the unit, but much greater than the reference range. However, these results indicate that the patient already developed relevant immunogenicity through vaccination. So immunogenicity is simply a response, an immune response to an antigen. So immunogenicity is, okay, you get the vaccine and you show antibodies. That's immunogenicity. But that doesn't necessarily mean that you have clinical immunity or whatever the case is. Your immunity is more of a global thing. The fact that you can show antibodies after a vaccine in and of itself is not proof that, hey, you're immune to that infection. So I want us to keep that in mind. So what did they find in postmortem? So they did pretty elaborate tests. Postmortem study revealed he had bilateral bronchopneumonia with abscesses, but there were no findings that commonly described COVID-19 associated pneumonitis. So the clinical findings were not consistent with COVID-19 pneumonitis. So in the heart, he had biventricular hypertrophy. For those who don't know, that's thickening of the heart. For our audience that doesn't know what that means, there's also the heart weight about 580 grams. Normal is 236 to 412. So pretty significant hypertrophy or enlargement of the heart. And he had ischemic cardiomyopathy. So that word ischemic is there. Remember, the colonoscopy biopsy showed ischemic colitis. And the autopsy of the heart showed ischemic cardiomyopathy. So what is ischemic? Ischemia is just subabnormal blood flows, tissue suffocation. So if you were to tie a tourniquet around your arm very tight, if your hand turned purple and blue, and then it started rotting and falling off, the early phases of purple and blue is lack of oxygen to the hand tissue, and that's ischemia. And then when it starts to rot off, that's infarction and tissue death. You don't want it to get to that point. But so there's poor circulation to the colon, poor circulation to the heart. Now, there's also amyloidosis of the transthyretin type. Now, this is the wild type transthyretin, and basically it's just due to accumulation of normal transthyretin protein in the heart muscle. And that's usually due to cell metabolism. This is probably a common finding in elderly people. It can contribute to enlargement of the heart and cause what we call diastolic dysfunction, or stiffening of the heart. It can also affect the conduction system. So oftentimes elderly people who need pacemakers, we used to refer to as Lev's disease or Lenegre's disease. This muscle protein accumulation contributes to that. I also think autoimmune components or inflammatory components can contribute to that as well. So this is a finding they had. The kidneys were both chronic damage, which we knew clinically, but there was also atherosclerosis and interstitial scarring of the kidney, as well as acute phase. So you had chronic kidney disease, and then he had acute kidney disease. There was acute damage to the kidney. So again, you can probably argue that he had ischemia in the kidneys as well. So here we go with ischemia in the colon, ischemia in the heart, and ischemia in the kidneys. An examination of the brain revealed pseudocystic tissue necrosis, an old infarct area. So why? What does that mean? He had a heart attack in the brain. So this person had what we call systemic atherosclerosis, or plaque in the arteries going to the brain, the heart, the colon, the kidneys. So he had systemic blocked artery. That's an important factor in this patient's situation, because when I start to go through the lab abnormalities, we're going to discuss, some of these findings. Here's some of the findings, and these are the pictures. I'm not going to bore you with the details, but one thing I'm going to point out to you, and I'm sorry for the small print, it's a busy slide. I just copied it from the article. The liver tested COVID negative, and also the olfactory bulb tested COVID negative. You see some inflammatory changes throughout all of the tissue here, but the only tissue that tested COVID negative is the liver and the olfactory bulb. The authors of the papers argue that this is likely due to the fact that this is a very recent infection. It's consistent with a recent infection. He had a more prolonged infection with coronavirus. It would have gotten to the eyes and into the liver. And so all these findings were consistent. The other thing I'll point out here is that the lung was positive, and the cycle time rate, again, this is very small, but I'm just going to call it out to you. The cycle time rate was 26.5, relatively low compared to the cycle time rate of all the other tissue that was positive. They were in the 30s. Now, I may be splitting hairs here, but it implies a higher viral load in the lung, and also implies entry site being the lung. So I think that's something that is worth mentioning, and we can discuss that. So conclusions, what were the summary? So in summary, this is the author's conclusion. These aren't necessarily mine. I'm going to get to mine in the discussion part. But the results of our autopsy case study of the patient with mRNA vaccine confirmed the view that by the first dose of vaccination of SARS-CoV-19, immunogenicity can already be induced. In other words, you can get an immune response by showing that the body can make antibodies. And so we saw that he had significantly large amount of antibodies made, but sterile immunity is not adequately developed. So sterile immunity meaning that the immune system cannot necessarily sterilize or prevent infection. As we see, he had antibodies, and a good number of antibodies. He had adequate antibody formation even after the first dose. So the vaccine, quote unquote, did what the vaccine is supposed to do, yet this patient contracted COVID infection. However, now he didn't get just a little bit of COVID, he had large amounts of COVID. It went to many organs, many tissue, etc. And so that's, that. So what I want to do, I want to take a little break here. Anybody, for my panel, anybody have any comments or burning thoughts before we go to break about what I presented? Any questions? We're going to get into the weeds in it later if you would like, but do you have any comments or questions? All right, so we're going to go to break real quick, and then when we come back, we're going to let the fireworks go. Okay, so we're back, and I'm going to leave my slides up because we're going to go through a few things, and I'll probably change out some of these slides. So let's just do a quick review and discussion. So what I want to do is outline some of the salient clinical factors. I think it's important to do that. And then I've got a busy slide after this. I'm going to go through the hospital course, which I think is important. So I always like to kind of step back and look at 30,000 feet. You know, where are we? Where do we start? What got us into this? Because sometimes we get into the details of, you know, what's happening with the patient, but we have to step back. So, okay, what started? What's the clinical presentation, and where did all this begin? And so basically, he's an 86-year-old man. He lives in a nursing home. That's the salient factor, and he received the vaccine. But nothing happened after that. So there was no early effects of the vaccine. Medical history had hypertension, chronic venous insufficiency, dementia, and prostate carcinoma. Now, the hypertension, you know, he probably had high cholesterol. I don't know that because they didn't give us that information. But, you know, given that other information, really doesn't matter. But he had atherosclerotic disease. They didn't mention that in the history. But hypertension, I would add atherosclerotic disease. We know that based on the findings on the autopsy. Venous insufficiency is just, you know, it's swelling and venous reflux in the lower extremity. That's a common finding in elderly people. Dementia is important because we saw evidence on the autopsy that had a stroke in the past. So he probably had ischemic dementia, so a poor circulation of blood to the brain. And prostate cancer at 86, you know, this is probably a physiological phenomenon as much as anything else. That's not quite correct, but it's a high incidence of prostate cancer in elderly people. And so it probably was diagnosed in his maybe late 70s and said, okay, let's do nothing about it, which is the appropriate thing. In other words, he tolerated the vaccine for 2 weeks, but on day 15, he passed out. Now, on the surface, you said, well, hey, could this be due to the vaccine? You know, people all over the internet say, well, hey, the vaccine, he got the shot and passed out on day 15, but he wasn't admitted for 2 to 3 days, so it probably wasn't too dramatic. But based on his clinical presentation on day 18, he was admitted to the hospital with worsening diarrhea. So he probably was having diarrhea throughout this time. Whether or not it was recognized fully, we don't know. He may have complained about it. It was recognized. They may have given him some Imodium. That probably did not work. And so it got worse. And so he's admitted in part because he was dehydrated. And so this is likely 3 or more days of diarrhea and probably poor oral intake. And who knows, it could be worse in terms of everything else. I don't know his medication list. That's not provided. But if he was on a diuretic, oftentimes he had a history of hypertension. Many times elderly people are put on hydrochlorothiazide, which is a diuretic. That could also be contributing to his dehydration. But he was COVID negative, so all must have been well. Now, again, as I emphasized earlier, he had ischemic colitis based on a colonoscopy biopsy. And he tested positive on day 25. And this is after being in a hospital for a week and after 24 hours exposure to somebody who's positive, and died on the 26th day or about the 8th day of his hospitalization. And probably 1 to 2 days after the COVID infection. So quite a dramatic, is this too small? Can y'all see this okay? I mean, I know it's a busy slide. Is that, in the chat room, can y'all give me a thumbs up if it's okay and a thumbs down if it's too small? I don't know if you have a thumbs down emoji. A panel, y'all, is it too small for y'all?
It's pretty small.
It's pretty small. Okay, hold on 1 second. Let me do this. I have a solution. I'm going to go and find. Let me go to my article here. It may not be too much better, but I'm going to give you the best I can. You know what?
Well, just go ahead and tell us what's on there. You can just go ahead and review it.
Yeah, no, I have it. I have the actual article. So I'm gonna give you a bigger view. How's that? Is that better? Okay. Well, either way. So on day one, we is vaccinated, and this is before he's in the hospital. Not much data, okay? No symptoms. Day 15, he collapsed at the breakfast table. No other clinical symptoms. Blood pressure 130/70. So it may have been a vagal spell or some transient passing out spell. Apparently, it wasn't major enough for them to admit him to the hospital. However, on day 18, now these are days counted from the vaccine. So they're referencing everything from post-vaccine. So day 18, he's admitted to the hospital for gastritis. And the leading clinical symptoms, diarrhea. So his diarrhea persisted. They did not mention GI bleeding. I want to emphasize that. They did not mention GI bleeding, but he did have diarrhea. He was afebrile. His blood pressure a little bit elevated here. That could be due to stress. I can explain that if anybody has a question. His oxygen saturation was good, so no fever, normal oxygen saturation, and he was COVID negative. So all the clinical symptoms, et cetera, is COVID negative. White blood count was not significantly elevated. It was normal, 6.6 in the normal range. I'll put quote unquote normal, so I'll comment on that later. Platelet counts are fine, et cetera. But look at here. I want to emphasize this anemia. Now, hemoglobin is 7.4. Now, I emphasized earlier dehydration and anemia. Now, hemoglobin is 7.4. For those people accustomed who are not very accustomed to labs, a normal hemoglobin, well, they have it right here, 14 to 18 in this lab. And normally from women, it can go down to those 12. But even if it was like 11, I'd be okay with it. But 7 is pretty low. Now, I will argue that this 7.4 is not real. I think this is a hemoconcentrated 7.4. And the reason I say that is because this patient is dehydrated. When you get dehydrated, the numbers get concentrated and they're higher. So even though I read 7.4, I'm going to argue that this hemoglobin was probably 6.4 or maybe 5.4 if he was truly hydrated, or euvolemic, as we say, which is very, very low. Now, that's important given some other factors here, but I'm going to go through here and point out a few things before I get to kind of, but keep in mind, low hemoglobin, and the creatinine was 1.91. It was abnormal. It's chronic renal failure. But look here, the C-reactive protein was not very high. It was high, but not very high. I would expect it to be much higher. So there was some significant inflammation, as we know, but the CRP was not as high as I would expect it to be, given all the things that's going on with this patient. And so as we go on to day 18, day 19, hemoglobin 7.1, 7.2. Now it goes up to 8.0. Now, I know in hospitals, when I'm rounding, we're always drawing blood, every day, multiple times a day. So this hemoglobin did not go up because they're giving him blood, because they're taking blood from him. I think his dehydration gets worse. And so I'm going to talk about that a little bit. Also, notice the white blood count. It's in the normal range, but then it goes up. If you go back here, the normal range of white blood count is 4 to 9 on their lab. And it goes up to 12.1 and 13.5 here. And so there's clearly some systemic inflammatory process, and the C-reactive protein goes to 2. It went from 1 to 0.8, and it's 2. And so it increases more, doubles, as well as the white count. So there's increasing inflammation that's going on. And then he's got anemia. They diagnosed the colitis, which is ischemic. And that's probably what brought him here, because he had diarrhea. And he started on the mesalazine, and he remains anemic. Now, mesalazine is used for inflammation due to an autoimmune process. He has inflammation due to an ischemic process, which is a lack of blood flow. It's almost like he's got coronary disease of the heart, i.e. blocked arteries leading to heart problems. He also has blocked arteries leading to colon problems, as well as blocked arteries leading to brain problems and blocked arteries leading to kidney problems. So when people have blocked arteries, and this for the sake of the people in the chat, the audience, blocked arteries mean that you have the inability to deliver oxygen to tissue, the inability to deliver oxygen to the colon, to the brain, to the kidneys, and everywhere else. Now, so when you have a patient with this condition, with poor circulation of blocked arteries or plaque in the arteries, and they have ischemic to tissue, you don't want them to be volume depleted, and you don't want them to be anemic. And this patient is volume depleted anemic. Now, I'm not reading the whole chart. I'm not saying whether they're giving them IV hydration or whatever the case is. I don't know its medication. So there are a lot of missing parts to this puzzle. But what I can say is that the kidney function is not getting significantly better. It actually gets a little worse. And the anemia persists, and it probably gets worse. The volume depletion, he becomes more inflamed. So this person, this patient, he did not get a blood transfusion. So if I were managing this patient on day one, he would be getting intravenous fluids. I'd be giving him IV blood transfusion. And that's just on the medical side. I haven't even gotten to the functional medicine stuff that I would be doing in terms of anti-inflammatory substances or the like. And my colleagues will probably chime in on that. But at the very, very least, I think this patient's clinical outcome could have been drastically affected in a positive way by simply giving him hydration and blood. And you can start with hydration, at least hydrate. Maybe you didn't want to, some people don't like to transfuse at 7.4. I don't transfuse numbers, I transfuse patient. And this patient needed a transfusion. I would have given him 3 units of packed red blood cells and 2 to 3 units of 2 to 3 liters of fluid from Jumpstart. So at the very least, I can argue that this patient, he really wasn't sick, he was thirsty and anemic. And those are the 2 things that could have, probably those 2 things alone, without all the other fancy stuff we can talk about, could have impacted its overall well-being. But anyway, I don't want to digress and belabor that point too much. So on day 24, notice his blood pressure. Yes, please.
Yeah, was there a blood urine BUN blood serum?
So let's see. They did not give. I'm sure they got that. They did not give the BUN.
Okay, I was just wondering when we were talking about hydration.
And I think you're probably alluding to the BUN to creatinine ratio, and I think that's a good point. It probably would have been high, but I still think that even without this, just based on the clinical history, I would argue that this guy was volume depleted, intravascularly volume depleted, and he needed hydration as well. But having the BUN would be very helpful. That's true. Now you can argue that his blood pressure went up, and so if he's dehydrated and anemic, why would his blood pressure go up? Well, when you're in shock, your body says, okay, I'm not perfusing the kidneys because they have less blood flow, less volume. Why am I, my blood pressure goes up? Well, the body secretes hormones that causes, the blood vessels to constrict. You have norepinephrine, epinephrine, those things, the angiotensin cascade kicks out, and you get angiotensin 2, which is a potent vasoconstrictor. It causes blood vessels to constrict. So blood pressure can go up even when your body's not perfusing very well. So he gets started on antibiotics. Chest x-ray shows some mild infection. They point out that he's dehydrated here. Lungs show some crackles. But, again, despite being dehydrated, his hemoglobin goes up. Now, he may have gotten some blood from here to here. I'm not sure. He may have gotten blood and IV hydration. But still, I don't think he probably got enough. Maybe got a unit here or there, some fluid or whatever. And I don't know what the treatment policies in this German hospital are. They may have restrictions on what they can give patients. And unfortunately, he died on day 26 at about 2:30 in the afternoon. And the cause of death in their report is acute renal and respiratory failure here. But he didn't have the typical COVID findings on Autopsy, and his I'm going to pull this screen out, and his but he did have positive PCR findings of COVID in the lungs, but not the typical infection. So just because there's colonization, it doesn't mean that there is actual infection. And so what I'm going to do is I'm going to throw a few more comments on COVID here, and then I'm going to get rid of my well, I'm just going to hide my slides. So I'm going to come share my screen one more time with my slides. And then, so just a few more COVID comments because we're talking about this patient. This man was 86 years old, and this is the COVID deaths in 2019. This is as of June 9th, so pretty recent data. And notice the bar graphs heavily in people older than 75, definitely older than 65. The median age, and I couldn't find the exact median age on the CDC website. I don't know if any of them know, but I've seen different sources in the past being somewhere around 78, 79, or 80. I saw one report 81, and the number probably shifts as the disease progresses over the months. But you can look here. The median age is definitely older than 74 because more than half. This is more than half the total number, and so it's probably somewhere around 78 years old in terms of the median age. And average age may not be too far from that. So this patient was, I would say, a typical patient, COVID death patient. And so I showed this slide to point that factor out because we often see on the news, they sensationalize, a young 35-year-old person who had perfect health, was out running marathons and, sniffed a little COVID and dropped dead. And then people get in their mind, that's the typical person who dies from COVID. But no, the typical person who dies from COVID is a patient that we just described. And I wanted to show that data to you as well. That's one point. The other point is that the vaccine. So and I looked this up before coming on. The first vaccine, I think it was dated roughly December 14th. If anybody has a correction to that, please correct me if I'm off. But at least mid-December was the first, shots were given. And that was like Pfizer was the first one out. The second dose wasn't given until a month after that. So, and I think they were doing 1 million shots a day. So the first 30 days, you can say about 30 million people. So from mid-December to mid-January, you had about 30 million people half vaccinated. And then to mid-February, you had about 10% of the people fully vaccinated. So that's probably a conservative estimate or an aggressive estimate. So here is January 2nd of 2021. And this number here is February 2nd, 2021. So it wasn't until after this that we had 10%. So we didn't have, the first people were not fully vaccinated until after this drop. And so the reason I'm pointing this out is that you had a drop in a drastic drop in COVID infections really before anybody was vaccinated to any significant amount. And please, colleagues, please interject and correct me if I'm wrong, but I think the first vaccines were completed. And the first shot was done December 14th. Second shot was January 14th, right about here. And so then you probably didn't get your first 10% or 20% of fully vaccinated people until somewhere along in here. And so so the vaccine did not create a herd immunity. This was probably a natural herd immunity. I think, what are we, about 40 nationwide, about 40+% vaccinated, 45, 47. Anybody know that number? Anyway, we're probably about 40+%. So herd immunity, you have to be at least about 60% herd immunity to get decent herd immunity. So the vaccine has not contributed to herd immunity. I think what this is natural herd immunity. And so I want to point that out as just additional comment. This is COVID comment. And I'm going to talk about coronavirus in the context of this patient and also globally. But there will be a time I'll do a more detailed discussion on coronavirus, the vaccine. I'm going to do that in a private setting. I'll announce it on the show. We'll give patients links to that because I won't have that discussion in the context of YouTube. But anyway, comments, smart remarks. I want to open the floor to everybody. And of course, thank you for your attention. And I'm going to stop sharing my screen so we can come to the Actually, I'll tell you what, I'm going to leave my screen in the background. Hold on. I'm going to leave it in the background in case somebody asks about a slide. I'll just leave it in the background. Anyway, any comments? I've been talking. I'm going to look, Joanne, Floyd, Pamela, anybody has a comment, question. And I'm going to say hello to everybody. Joanne, you have your hand up. Go ahead.
So, I mean, the first question I have is, could this possibly be, with what we're seeing here, is an example of what was called antibody-dependent immune enhancement, which was one of the things that had been observed in some of the previous animal studies with some coronavirus vaccines. And so I don't know. I'm just wondering, could that be what happened in this case?
You know, it's certainly possible. Now, the thing is that so let me back up and kind of restate the question for our people in the audience, in the chat room. So the antibody-dependent immune enhancement, and somebody referred to it so that there's that syndrome, which I think is part of the syndrome of pathogenic autoimmunity. And so then the question is, and when the animal studies were done with the previous mRNA vaccines, they were used ferrets. And so the ferrets showed immunogenicity like this patient did. But then when the ferrets were exposed to the wild type virus, as this patient was, all the ferrets died. And they all had their lungs fill up, they had acute respiratory failure, and they died. And so we have a similar clinical scenario here where this patient was vaccinated, had immunogenicity, so he showed antibody response, normal antibody response. But then he was exposed to the wild virus, and they showed that it wasn't a mutant, it was the wild type virus. And he contracted it pretty aggressively because it was, in just about 24 hours, he had not just a mild infection. He was, and they emphasized that he was strongly positive. It only took a small cycle time to detect it. So he had a very high viral load in a very short period of time. So this, on the clinical side, is similar to what was seen in animals, where you get the vaccine and you had this, autoimmunity or vaccine enhancement of the infection. And so there are different mechanisms that probably play a role into that. There's one mechanism of triggered autoimmunity, which is one thing, which may not be the case here, but viral enhancement of the infection. Dr. What's his name? The guy from overseas, Bush. Help me out, Joanne. Dr. Bosch. Dr. Bosch. I think it's Dr. Bosch. Anyway, you know who I'm talking about, right? You're muted.
If I'm sorry.
That's right.
Hitting the wrong buttons. Vanden Bosch, I think was
Vanden Bosch. Yeah, Vanden Bosch. I forget so Dr. Vanden Bosch, and he's written on this and he's spoken extensively on this, and his comment is that it's problematic, to get the vaccine in the setting of a pandemic because one of the things that happens that you force the immune system to make a specific type of antibody, but your natural immunity expresses antibodies to more global aspects of the virus. So in other words, notice they saw IgG, the spike protein, sub-1 particle, but the antibody, the virus has many different parts, and so you can have an infection that come in, and you're making one specific type of antibody, but your global immunity is suppressed because all of your energy and immune function is going toward making this antibody because the way this vaccine works, it forces you to make more and more and more IgG antibodies of the specific type. but your natural immune system may make a spectrum of IgG antibodies, some to the sub-1 particle, some to the sub-2 particle, some to the binding component, some to the nuclear capsid of the virus. So that many different parts of the virus you'll make antibodies to. Some parts of multiple parts of the spike protein, the nuclear capsid, and other parts of the virus. But here, he's making a lot of it, all your energy and protein stuff and machinery is going toward making just one specific antibody when there are other antibodies that may be important. And so that's part of the mechanism. Now, again, you can't, show that case in one situation, but the data here suggests that he clearly had a severe infection with the vaccine, and he then had a rapid onset despite antibodies to COVID. Because you would think with these antibodies hanging around, these guys are asleep or something because he got exposed to the COVID virus, and they did nothing. It did nothing. In fact, it seemed to allow him to get the infection faster and more ferociously. So that's a good point.
I thought I also noticed in there they mentioned binding antibodies. And I thought I recalled that there could be binding and neutralizing antibodies, and that was also one of the concerns that had been raised in some of the animal studies, was that you had a lot of binding antibodies created, but you didn't get enough of the neutralizing. And if I understood this paper correctly, and I might not have, but if I understood it, it sounded like there were binding antibodies, and I didn't see them mention neutralizing.
Well, that's correct. So what they show, now again, I can only talk about what they did show, and you might mute yourself because I think I'm coming out on the other end of your mic. Just mute and unmute. But anyway, so I think you're correct, because what they showed, the high antibody titer was to the sub-1 component of the spike protein. That's it. Your immune system, when you see the virus, it says, hey, I see your eyes look like this, your nose look like this, you got feet that's shaped this way, you got arms that's shaped, your elbows, and I'm gonna put antibodies to all of that stuff. And it does things and it neutralizes, but plus, if you bind to a certain part of the spike protein, it doesn't necessarily prevent the vaccine from being incorporated or binding to cells and getting it encapsulated into your cells or invading tissue. As we find out here, we saw it did not prevent the virus from invading tissue because it went to the lungs and it went to several tissue sites that were COVID positive. And you would think he was for 20 days, probably 24 days. We know he was COVID negative for 20 days after the vaccine, and probably 24 days. And because on the 24th day, he was exposed to his roommate, and the 25th day, he was COVID positive. So we said at least 20 days. So in that period of time, he had adequate antibody formation. His immune system should have been primed and ready to go. Now, other people argue, say, well, this requires 2 shots, so you needed a booster shot, et cetera, and that's why you need to boost the shot to get a higher, immunogenicity. I don't know if that was the case with this patient because he had adequate antibodies, and you're only going to make more of the same antibodies. So enough antibodies are enough antibodies. And so this autopsy reveals a lot in terms of the inadequacy here in terms of preventing severe infection. So let's see. So Nicole is saying, clearly eager to see where you're going with this. So far, I'm not surprised. He got COVID and died. He was super unhealthy and only had 1 dose of the vaccine. Now, okay, great. Where am I going with this, Nicole? I'm glad you. Here's the bullet point. Here's my one. Did this patient die from COVID? In my opinion, yes and no. The ultimate answer, no. This patient died from being sick. Now that seems kind of crazy to say that, but let's go back to the beginning. Because I like Nicole's question where I'm kind of beating around the bush. He said, "Hurry up and get to the point." Montgomery, I got stuff to do. Okay, I get it, Nicole. So the point is this: the patient had systemic atherosclerosis. He was anemic. He was dehydrated. If you took COVID out of the picture, I think he would have died anyway. COVID just kind of helped nudge him along Maybe he'd have died a week later, an hour later. I don't know. But COVID certainly nudged him along and contributed. But if you hydrate him, correct his anemia, then you, and of course, he's at risk for COVID infection, and he's immune compromised. Why is he immune compromised? He's not just because he's 86. He's immune compromised because he has ischemic colitis, and he probably has ischemia in other parts of the GI tract. And so his microbiome is probably abnormal, and the human microbiome contributes to the immune system. So he's immune compromised to the systemic illness and the fact that he does not have adequate blood flow to his tissue, i.e. the colon. So immunocompromisation is in part due probably to the poor diet they serve him at the nursing home. That's speculation, but I think I'm right. Also the polypharmacy, that's speculation. I think I'm right. That's destroying the the microbiome. So he's immune compromised because of that. Ischemia makes it worse. He's anemic, which exacerbates the ischemia. So had he gotten hydration and blood initially, I think that would have helped him out tremendously. So the vaccine, I don't think helped him. And as Joanne alluded to, it might have even given him a disadvantage. I can't say that for a fact, but I do know it didn't help him because he contracted the infection despite that. Only having one vaccine, I don't think is a great excuse, quote unquote, because in every case, we don't quantify the amount of antibodies after the first shot. In this case, he had adequate antibodies after the first shot. The second shot was only going to give him more antibodies. That's not necessarily going to give him more immune protection. It's going to just give him more antibodies, etc. You know, if you hire 1,000 lazy workers and they're all standing around on the pay clock and doing nothing, do you think hiring another 1,000 workers to hang around and do nothing is going to make the job get done faster? No. And so these antibodies are just hanging around. And so they were just binding, but they probably weren't preventing anything. It may have been causing more problems. So I think this patient died due to the fact that he wasn't adequately managed, in my opinion, as many patients are not. And he had an acute flare-up. He had ischemia to his colon. He had diarrhea, and that's what led him to go. He probably had microinfarcts to other parts of his bowel. He was immunocompromised because of his systemic illness. He probably had liver dysfunction as well, but we don't have labs. We can't speak to that. But with polypharmacy, it probably contributes to that as well. So I think he died due to systemic ischemia, contributing to immune compromised state due to his bowel being abnormal. He caught a pneumonia due to his suppressed immune system, due to his chronic illness, and he did not overcome this pneumonia. I think COVID was the pneumonia, but he also had evidence of other types. So he had bacteria and other things. So other kinds of things could have caused the pneumonia and killed him as well. But COVID would not have killed him had he been better cared for, had his total body, his organ system been better treated. That's the take-home message I want to get to Nicole and everybody else. Yeah, yes, Pam, you had your hand up, and then Joanne.
I think Joanne had her hand up. I didn't have my hand up.
Okay. Yeah, all right. Go ahead.
So I had a bunch of questions come up as you were talking.
Oh, no problem.
The first is ischemia to the colon present with diarrhea? That's the first question.
Yes.
It can. Okay.
Yes.
And so then my question is, could the vaccine have played a role in that suddenly presenting or getting worse at that particular time?
I'm sorry, what's that other question again?
So if in fact the ischemia could have presented with the diarrhea, is it possible that the vaccine stirred up inflammation in a way that contributed to the blood supply getting restricted to the colon at that time? That's another question.
Okay, yeah. It's certainly possible, but here's the thing. It's hard to know. It's certainly possible. It's one of those things like you've got a lot of kids throwing rocks and a window breaks and you don't know which rock, breaks the window. And I look at the vaccine as just another rock being thrown at the window. And even though some people argue it was to protect him, but it doesn't really protect him because he's got a lot of chronic illnesses and he's at increased risk of having an acute flare-up. And to the point that you're alluding to, yes, the vaccine can cause a worsening of the problem because it's an inflammatory flare. But he might have had fried chicken the night before. I have no idea. And so if you got a lot of people throwing rocks and the window breaks, and it's like, I remember I was a little kid, we were all throwing rocks and stuff, and a window broke, and they called the police out, and we were all nervous. And nobody knew who broke the window. And it's like, we were just throwing rocks. And so, so the vaccine is one of those rocks. And could the vaccine have contributed to that? It's hard to say. But there was a 14-day period where he was asymptomatic, quote unquote. I don't know when the diarrhea started. So you certainly can't say that it wasn't a vaccine. You can't say that it was a vaccine. It's just one of many rocks that are being thrown at this unfortunate 86-year-old man.
Okay. And then here's the last question was that I noticed they documented that viral RNA was found in most of his major organs upon autopsy.
Mm-hmm.
And so I'm curious, and I don't know if this is the case or not, but is there a way to distinguish between that RNA sequence that was discovered, to distinguish if it came from the wild COVID or if it was the vaccine RNA?
So there is a way of distinguishing. What they did say at the very beginning was that there was no mutants. They outlined certain mutants that they were negative in the test. So I don't recall whether they did that distinction in every teacher. I think they did. They said that there was no mutant found, but they weren't very clear as to whether they did that differentiation for all the tests. But I think certainly in the lungs they did it, and I suspect they did it in other tissue. But they did outline that they looked for mutants and specific ones. I don't have the ones. In fact, I'll pull up my article while we're thinking. But they clearly said that they saw mutants. They did not show any mutants. Let's see. So let's see. There was no evidence on further analysis of the swab type. Now, this was probably the nasal swab on day 25. So no evidence for mutant SARS-CoV variants of B.1.17, B.1351, or B.1.1.28.1. So there were three particular variants that they were looking for, and apparently these were variants that had been found in that environment. So those particular variants were not seen of those three. But there are other variants around that I'm not aware of. But they did look for some variants and did not see them. But that's a important question. Next, any other questions?
Was it ever said that when the last time he was tested before all this happened, the last time he was tested, received a negative COVID test prior to the vaccine?
The last. So you asked him the last negative COVID test prior to the vaccine?
Yes.
Now they didn't give that data. They gave. In fact, they did not explicitly state that he was negative at any time prior to. He was just negative when he went into the hospital, and they're just letting us assume that he was negative prior to, since he was negative. Then the latest negative test for COVID was 20 days after the vaccine. That's the latest negative test, and he had, I think, about three tests or something like that prior to, including that test. Any other comments or questions from the panel? Sean is asking about beta thalassemia. Sean, thalassemias, many times they're not treated. Most are benign. I see a lot of thalassemias. I don't treat them. I see them. If it needs to be treated, I'll send it to hematologists. There's a simple way that I usually diagnose thalassemia. I look at the red blood count. If the RBC count, typically the RBC is 1/3 the hemoglobin number. So like if an RBC is 5 and the hemoglobin is 15, that's the normal ratio. But sometimes I see an RBC count of 6.5 and a hemoglobin of 10. And then that clues me that it may be a thalassemia. Then if I see the MCV is low and the RDW is normal, then I'm pretty certain it's very likely a thalassemia. Now, if the person is not severely anemic, oftentimes the anemia is very mild, or they're not anemic at all. I've seen a lot of thalassemias where they have low MCVs, the cells, the red cells are small, and the RBC, the hemoglobin ratio is off, and so they have a thalassemia, but they're not anemic. And in fact, I saw a lab today with somebody who's a thalassemia on one of my patients, but they weren't anemic, so I don't do anything about it most of the time. Big pharma's protected from legal liability if the vaccine kills you. Yeah, I can't say the vaccine did or didn't kill. And that's the other thing about vaccine. That's one thing, and it goes to the question you asked, Joanne. It's hard to distinguish whether somebody died from a vaccine or died from something other than a vaccine. Because let's say you get the vaccine and you die 2 days later of a massive stroke. Vaccine is going to increase coagulation, but other things can do it too. Pulmonary embolism. I've had a number of people with post-stroke vaccines after the first dose. I said, don't get the second dose. I've had patients with acute coronary syndrome being admitted post-vaccination. Post-pulmonary embolism. A patient, after the J&J vaccine, had a post-vaccine pulmonary embolism 2 weeks later. And so I've seen a lot of patients with these post-vaccine syndromes. And what I tell them is that, if your MCV is normal, Sean, then you may not have a thalassemia, but I'm not sure. I have to look at the whole panel. But I can't tell them for sure that the vaccine caused the problem. And it's RFK Jr. made this point when he was on one of his panels. He was talking about, and he made the comment about Hank Aaron, who died 2 weeks after the vaccine. And he said, wow, he just made the comment, he died 2 weeks after the vaccine, and the press jumped all over him. And so they, the audience is fascinated with thalassemia. So maybe we need to do a talk on thalassemia. But anyway, so he made the comment, it's unfortunately died 2 weeks after. And then the press jumped his case and said, hey, the autopsy was done and he didn't die from the vaccine. And RFK Jr. said, that's unusual. You can't, he actually called the coroner. And, after a little bit of waiting, spoke to the coroner, and they said, well, we never did an autopsy. But the point he made was, and so the press lied about it. That's one issue. But the other issue is that he made the key points that it's really hard you really can't distinguish in most cases. Now, there's some extreme cases where you have, platelet consumption, coagulopathy, and various other things. And you may do some special tests and see some, abnormal findings with, vaccine, antibody complexes or whatever. I'm not sure. But in most cases, the vaccine triggers an inflammation, and it could be one of many rocks that are being thrown. And you just don't know whether it's that or not. So anyway, any other comments? This is I hope you all enjoyed this. I kind of talked a lot, but there were a number of good questions here. More comments and questions. Boy, a lot of people have. Somebody said water's the key. Let's see here. One last comment. Thanks for okay, gets much for you, Zach. Okay, any other comments or questions before we close out? All right, so thanks for sharing this article, Joanne. Thanks for joining us, Dr. Atkins and Dr. Atkins. And I will see you guys backstage in a few minutes as I close out. And so again, I hope you all enjoy that. We'll probably do other scenarios where we present case histories. I'll probably present patients that I manage and do some clinical discussion, because I think it really helps, at least I hope it helps in the audience to understand what happens with an individual patient and how to potentially extrapolate that to normal people. The nice thing about this publication is that, one, it gave the typical what I think is a typical scenario with an elderly person dying with positive COVID. So on the surface, you say, okay, 86-year-old man died from COVID. But when you really look at the details of this case, it's not as simple as that. Yes, he had the vaccine, and yes, he had an antibody response, a very good response to antibodies from the vaccine. So you can argue he needed the second shot, but not necessarily, because he had antibodies from the first shot. So he should have had some protection at least. But despite that, he had a very rapid, sudden infection. Could it be due to the vaccine itself? That's an argument. Yes, it could be. Could it be due to something else? Yes, it could be. But overall, what we do know is this gentleman had a lot of systemic illnesses, and the body works in concert. You can think of it as a team. So you may have one component that's weak and another component that's fully functional. But one thing you really want to understand is that if you have all the organs and organ systems functioning at their highest level possible, then these organ systems can work in concert. Sometimes, one team member can compensate for another team member who may not be, on their top of their game in one situation, or maybe sick one day. And the body works in a similar fashion. So different parts of the body can compensate for others. However, if you have, the global aspect, the kidneys are not working well, the heart's not working well, the GI tract is not working well, probably the liver wasn't working well. So you have multiple organ systems that are not functioning normal, plus it's anemic and dehydrated, and these things aren't corrected. Then this patient dies for many reasons, not just because he had a positive test for COVID. And I think hopefully I got that message across, because it's easy to sort of globally say, oh, yeah, COVID positive. Yeah, he had a positive COVID test and had COVID pneumonia. But what led to that wasn't so much that the COVID infection was so virulent. It was just that he was so compromised. That's the key point, and that's the take-home point. And I hope you all got a lot out of that. If you did, make sure you subscribe. If you haven't, make sure you also share with loved ones who can benefit from this information. And of course, hit the notification button so you can get notified on our future broadcast. But until next time, keep it fresh, natural, and live.